With the kind permission of today's chair, good afternoon all. I am Dr. Mustafa Aziz Shuman. Welcome you all in our weekly scheduled virtual academic session. Today's faculty, Dr. AFM Kamal Uddin, Assistant Professor and Consultant of United Hospital, and his topics, Role of SBRT in Lung Cancer Management. Especially, he will cover non-small cell lung cancer. It's an honor to introduce Dr. AFM Kamal Uddin, whom we used to say Kamal Bhai. He is a very good mentor, guardian, and well-wisher who always thinks for the future of his junior colleagues. This virtual academic platform, virtual preceptorship, workshop, whatever academic activities you can find by Oncology Club is his main initiative. Beside him, we do have three distinguished overseas faculties. Right now, JP sir is with us, and two probably Ullash Batra and John Conevier will join us with soon. Professor JP Agarwal sir, a very time-tested friend of radiation oncology community of Bangladesh. He is the head of Department of Radiation Oncology Department of TMC, Mumbai, India. I don't think he needs more introduction. His name JP is fair enough to give his introduction. Our second faculties who are supposed to join within a short of time, Dr. Ullash Batra, another well-wisher for the future of Oncology Society of Bangladesh, who always responds any positive initiative. In spite of his very busy schedule, he always used to respond in our any invitation. He is the Senior Consultant of Medical Oncology, Department of Rajiv Gandhi Institute, Delhi, India. And we do have Dr. John Conevier. I am not seeing him still, probably he will come later. He is the Consultant Clinical Oncologist, St. Bartholomew's Hospital, UK. Now, I thank you all for giving your precious time over here. I would like to request our President, Professor M.A. Heiser, to officially start the program. Professor M.A. Heiser.
Thank you, Dr. Shuman. Bismillahirrahmanirrahim. Welcome you all in this afternoon. I can see we're already 25 who joined now. No waits could not join yet, or two faculties. Hopefully they will be joining us. And JP has already joined. Without delay, I think we should start our activities. So I declare it open. Kamal, please start your deliberation.
Thank you, sir. Before Kamal Bhai, I just want to give a recap our program design. At first, Kamal Bhai will give his delivery. It will be around 20-25 minutes. After that, there will be comments from the overseas faculties. And if any question is there, you have requested to put it in the chat box so we can discuss it later. After the question answer session, there will be case discussion regarding today's topics. And after that, there will be quiz and the wrap-up session. So over to Kamal Bhai for his presentation.
Thank you, Shuman. Such a wonderful introduction. I feel honored. So it is quite special for me to make this presentation for many reasons. First of all, among the whole virtual program today, I was always doing the moderation. Today, I changed my chair and give it to some than me and take my chair. So welcome Shuman to be the moderator of the subsequent session. Secondly, I am having a faculty whom I met in 2001 in Tata Memorial Hospital. And he is not only a wonderful oncologist, but he is the best person I have ever met. So thanks JP for being with me. And definitely talking on SBRT is something interesting because we had some small experience in Bangladesh and we have gone through quite a big hurdle. And I'm working in this ENT institute, but this all radiation treatment that I do in this nice hospital is United Hospital. So I'll be trying to touch the SBRT non-small cell lung cancer in early stage, and I will be slightly touching oligometastasis because this is another big chapter. We should not talk much on that because it will then become a boring thing. So I want to acknowledge Karthik, who is the person for whom I can do all this challenging thing in our hospital, United, one of the most brilliant medical physicists I have ever seen, and also to all my team colleagues, United, because this is a teamwork, and I cannot forget all the courageous patients, but who was courageous enough to submit them under our inadequate knowledge to be treated. So I always try to start with remembering this great man, ABMF Karim. He was an emeritus professor in Pre-University, but for us, it is a matter of pride that this emeritus professor of European University is a man of our country, so we can claim that we are from the same land. So we are talking on lung cancer, and we know globally it is one of the biggest killer, and in Bangladesh situation is not very, quite alarming, because as per Globocon 2018, the incidence and death rate is quite high with lung cancer. So we start with a case of a 60-year-old man, squamous cell lung cancer, left upper lobe lesion. And radiologically, after doing PET, it was CT1N0M0, and there was no comorbidity. So if you ask a question to any of the colleagues that what should be the treatment, surgery, conventional radiotherapy, chemotherapy, or immunotherapy, I'm sure the answer will be surgery. But if we change the situation that the patient is now a 90 years old male, having the same lesion, and the ejection fraction is only 25%, and if pulmonary function test is 40%, or the same 60 years old man, but he is desperate that he will not undergo any surgery. So then what could be the solution? So in this region, whenever we oncologists land in some problem, we always take the support of NCCN. NCCN guideline 2020 is telling that, well, this type of patient, if they're not operable, then we can do some treatment called SAVER, definitive treatment SAVER. So what is SAVER? So SAVER is stereotactic ablative radiotherapy or stereotactic body radiotherapy, SBRT or stereotactic ablative body radiotherapy. It's a technique which used to deliver a high ablative dose with a BED of more than 100 gray, and in a number of 5 fraction, but this is a query because now up to 5 is no more, somebody using more higher fraction, and the target should be extracranial, because when it is intracranial, it becomes SRS and single fraction. So all these wonderful instruments like this TrueBeam or this CyberKnife or this tomotherapy or this Vero, all this can be used to treat the patient with SAVER. So if you look at this graph, you can see that from 2000 to 2010, there was a rapid rise of SAVER. And if you look at the same paper, the highest number of organ that was used for treatment by SAVER is lung cancer. And this National Cancer Database data of 2004 to 2015, you can see what a sharp rise of use of SAVER when the conventional radiotherapy was falling down in treatment of early stage non-small cell lung cancer. So why it became so popular? Because with conventional radiotherapy, when the local control we could achieve is 30%, but the SAVER can achieve a local control of 90%, which is comparable with surgery. This is an interesting paper published in Lancet. Our Australian group, they have done a randomized control trial to compare the conventional 3-dimensional radiotherapy with SAVER for early stage lung cancer. And they have shown that the SAVER is showing both higher overall survival and freedom from local failure. And here the hazard ratio was 0.32 and 0.5. There was a meta-analysis which was published in radiotherapy and oncology. And they have shown the data of 895 versus 1300 plus EBRT patient. And 2 years OS was 70% versus 53%. And DFS was 83% versus around 67%. So we can conclude that with this evidence that it is convincing that SABR is better than conventional radiotherapy. So what is the data of SABR in inoperable lung cancer? There are quite a good many studies are there. I have picked quite a few of them, but all are phase 3. And you can see that they have used different fractionation, different number of patients. And if you summarize the outcome, you can see that 3-year overall survival is from 42 to 71%, 71 months. And local control, 3 years is around 878 to around 97+%, which is quite encouraging. And among them, the RTOG trial, that was a landmark trial by Timmerman, who was one of the pioneer of SABR in lung cancer. They have shown that the survival, 3-year survival, OS and DFS of T1 to T2 lesion, which was 58%, 55% and 43%, which was quite encouraging. So now when we are trying to say that we are achieving a local control compared to surgery, then the question will come, what about comparison with surgery versus SABR? So these are the list of trials. They have done the comparison, or these are all prospective. And if you sum up, you can see the 3 to 5 years overall survival rates with SBRT range from 77 to 95%. And 5-year cause-specific survival rates was 82 to 90%. But due to its design and retrospective nature, we cannot take it as a valid data to fight with our surgeon colleagues against surgery. So what we need randomized trial. But unfortunately, these are the 4 randomized trials which were terminated. But some colleagues took the data of incomplete these 2 trial, and they have then done a pool analysis. And the second author of this paper is Suresh Senan. He is from the Free University, where our founder of Oncology Club, Professor Karim Sir, was emeritus professor. So what they have shown in a small series that in OS, in recurrent-free survival, and freedom for and in distant metastasis, in most of the field, SABR is doing better than surgery. But they have concluded that SABR could be an option for treating operable stage 1 non-small cell lung cancer, but the small sample size and short follow-up cannot make a definitive conclusion to be a superiority over surgery. But still, this is the evidence that we have from the STARS and ROSAL trial, that we had some data where we have some superiority over surgery. So these are the 4 randomized trials that going on. 2 in US, 1 in UK, and 1 is China. And all are eagerly waiting to see the outcome of this trial. So now, what are the dose fractionation that we should use in SABR? This NCCN 2020, you can see that they have recommended different type of dose fractionation, and from 1 to 10 fraction. So less the fraction, less the tumor dose per fraction, because you can understand that when we are using 1 fraction, we cannot go beyond 34. But the dose per fraction goes down and the total dose increases when we go for higher fraction. When it's a peripheral tumor, we can use a smaller fraction, and we can use 45 to 60 or 48 to 50 by 3 to 4 fraction. But when it is a central tumor, then the fraction size number will increase and the fraction size will decrease, because we know that if a higher dose we use in the central tumor, there is a risk of higher toxicity. And if you look at all the fractionation, the principle is they were trying to get a BED of more than 100. So what is the secret of this 100 BED? This was a paper published by Onishi et al. In Cancer in 2004. That old paper, they have shown that in addition to the tumor size, the BED more than 100 and less than 100 make a significant effect on the survival in early stage lung cancer when treated with radiotherapy. So this is the basis where from this magic number 100 BED came. Then few words about the central tumor and ultracentral tumor. This is the no-fly zone. Previously we used to say as central tumor, but now they say you can fly with some caution, but real red zone is this ultracentral tumor. So in this 2020 NCCN, they have defined that central tumor is within 2 centimeters of the proximal bronchial tree and or abutting mediastinal pleura. An ultracentral tumor defined as abutting the proximal bronchial tree. So this is the area that we need to think when the tumor is away from this, it's a peripheral tumor, we can take a risk and we can become very aggressive. But when we are approaching more central zone, we should be cautious about our planning and dose fractionation. So NCCN is telling that when it's ultracentral zone especially, we should use the risk-adapted tumor, risk-adapted planning, tumor dose fractionation. So this risk-adapted SBRT is that whenever you are approaching towards central, you need to increase the fraction and dose per fraction. So you can see, so 3 fraction 18 grade T1 lesion or single fraction 30 to 34 in peripheral. But when it's ultracentral, it is 8 fraction, 7.5 gray per fraction. So the total things change. So whenever we are approaching towards the central location, we need to take care of the number of fraction and dose per fraction to avoid any unwanted side effect like stenosis of principal bronchus. So there may be a question that sometimes we come to a situation that a very small tumor cannot do a biopsy, but we are convinced that it is a lung cancer. So can we do a SAVR without pathology? There are many guidelines, ESMO, ESTRO, and Asian Clinical Practice Consensus Guideline. Everybody said preferred is doing the pathology, but in some situation, if we are really convinced about the pathology and in a multidisciplinary tumor board, if all agree, we can treat without pathology also by SAVR. So what about the toxicity? Is it something without toxicity? The answer is no. Even the great center like Memorial Sloan Kettering centers are not immune from this toxicity. Say when it's a peripheral tumor, we need to take care of the skin toxicity and rib fracture. But good news is if you can really do a good treatment, the toxicity is not very grave. All the toxicities are acceptable percentage and low grade. If there is no previous lung pathology, then the toxicity is within tolerable limit. But it adds when the patient had additional comorbidity. Few words about SAVR in elderly. If you look at this paper, you can see that if you see the blue area, this is the utilization of radiotherapy. From 2001 to 2007, there is an increase of use of treatment, and the increase is not in the surgery area, but in the radiotherapy area. And this is due to the introduction of SAVR. They have concluded that introduction of SAVR has made an increase of absolute 16% increase of RT and decline of proportion of untreated elderly patients, and also showed an improvement in overall survival. So very quick words about oligometastasis. It is a new concept which was proposed in an editorial by Westblom and Hellman in 1995. They have said it is intermediate biological state for restricted metastatic capacity, limited number and organ site of metastasis, transitional state to dissemination. So we can say that oligometastasis is something between local disease and metastatic disease and have a potential of cure if we can adequately treat the patient. So is there any oligometastasis in lung cancer, non-small cell lung cancer? So this was a systemic review, and they have taken data of many 2,117 patients, and they have concluded, yes, there is a existence of oligometastasis in non-small cell lung cancer, and if we can aggressively treat it, it can offer a better survival. But there are some confusing terminology. Say, whether it is primary oligometastasis or oligorecurrence. What is the cutoff of metastatic size? 1, 1 to 2, or 1 to 5? Metastasis on one distant organ, or 2, or in 3. Whether there is mediastinal lymph node positive or negative. All these are the issues that make sometimes our handling of oligometastasis confusing. So do you have data for treating oligometastasis? So always we look for randomized controlled trial. So this is a trial of 49 patients. They have randomized 1:1, and they have shown that when the oligometastasis were treated by SBRT, aggressive treatment, the consolidation group has shown a PFS survival of almost 12 months compared to only maintenance group of 3.9 months. So consolidative therapy, either surgery or radical radiotherapy, offered a significant higher survival. And this is another RCT, phase 2 RCT, published in JAMA in 2018. And they have taken 34 patients. Finally, they have analyzed the data of 29 patients. And they have shown that SAVOR was showing PFS of 9.7 months compared to maintenance only patient with 3.5 months. But this patient trial was terminated, accrual was terminated prematurely for seeing this data. So the two ongoing trial is going on, the STOP trial and HALT trial on oligometastasis, and hopefully this will give us more convincing data. There is a meta-analysis, and it was published in Journal of Thoracic Discipline, and they have taken almost 3,900 studies, but finally they have taken only 7 to analyze, and these are the 7 trials. And what they have concluded that in all the group, the aggressive thoracic treatment was showing favorable response. And if you look at the cumulative overall survival, aggressive thoracic treatment is showing a clean-cut superiority over no aggressive survival, no aggressive treatment. And the OS was significant, the p-value was quite significant. And pooled survival rate of 1, 2, and 4 years was 75%, 52%, 23% against 12, 32, 32, 13, and 3.7 versus 2%. So you can see there's a huge difference. In 1 year, it is around 75% when we're doing aggressive treatment compared to 32%, and so on when we go on 1 to 4 years. So the curative intent of oligometastasis is complete resection or radical treatment of the primary tumor and treatment to all metastatic site, either by surgical metastatectomy, SAVOR or RFA, and then continue the systematic therapy. So in the election, Mr. Obama said that we need change, and change happened. In 2010, he was the president. In 2020, he is no more the president. Now, Mr. Trump, unfortunately, who is now in the hospital, is Mr. President. So what happened in Bangladesh? In 2010, I made a presentation that a hope in the horizon, stereotactic body radiotherapy, early stage lung cancer. But what about today? In September 2020, I got a call from Sylhet, one of my colleagues. He said that, hey, Kamal, we have a patient, probably you can treat him. So the patient presented with a cough. He was a 70-year-old man having severe comorbidity. And initially he presented with a dense opacity in left mid-zone. And the histopathology was adenocarcinoma. And then we did a PET CT and MRI. Finally, we came out to be a 4.5 by 3.2 centimeter lesion. And MRI confirmed there is no cerebral metastasis. So we treat the patient from 23rd September to 3rd October with 50 gray in 5 fractions. So in 2020, we can say that it is a reality. So this is the patient image, and we have done the contouring on 4D CT image. And then the treatment planning was done by 10 MB FFF beam with 2 half arc. And you can see the dose distribution on 4D CT. That Karthik has done a wonderful job, and the dose distribution has fantastically covered our target area. And this is the image guidance, that how we do everyday image guidance by both KB and CBCT. So what is the prerequisite of doing starting SBRT? We need the appropriate equipments. We need strict immobilization, because we need to remember that Saber came from SRS. SRS was intracranial lesion, and there the frame was used with a screw, and not even a millimeter movement was allowed. So we need to do not only immobilization, also take care of the motion. That is, we need to do 4D CT. We need to do normal tissue contouring following any standard guideline. And also we need to take care of the OR doses. And we need to give the prescription either on 3D CRT or IMRT or VMAT basis. Those concentration plan constraints should be very critically evaluated. Plan evaluation should be done as a team by cross-checking, and tumor tracking and tumor delivery by CBCT. So in United, we had a small experience, and our experience we have submitted for publication to ASTRO this year. It was accepted as a poster, where we have shown that we have done almost good number of lung cancer patients, and our experience was quite encouraging. So for lung, till now we have treated 28 patients, where 17 was male and 11 was female. And all of them were T1, T2, M0, M0. And we have done 11 metastatic cases, where all were primary were breast, except one was RCC. And all our tumor was less than 5 centimeters. We always treat this histologically proven tumor. We always treat less than 5 centimeters. We use PET CT and MRI brain, and always take patient for not fit for surgery, and any patient who is seriously unwilling for surgery. This is how we do the CT data acquisition. Then we do the 4D CT. And then we use this GE scanner and burial real-time positioning RPM system. And this is how it looks. And we do the contouring on the average, CT average. And then we do the OR. We do the lung, trachea, and esophagus, and heart, and normal lung also. Rib, sometimes it is a peripheral tumor. So if you look that, if you see at this image, this is the CTV and this is the PTV. But when we consider the motion, then we need to think that we need to consider the ITV, because we need to cover the area with the motion, and we need to put a margin on ITV. Because if I do that, don't take a consideration of the tumor motion, then we use MIP, so that we use ITV, and then average IP is used for dose calculation. And then we always use a 5 millimeter margin around the ITV. So this is how finally the contouring is done, and our physicist colleague use number of arc required to do the planning, and they see the dose distribution, and then they use always triple F beam, and 1400 to 2400 MU per minute dose rate is used, coplanar beam is used, and plan normalization is done on target mean. So it is a case that we have treated, 63-year-old patient in 2016, and follow up after 3 years. You can see that after 6 months it has gone, and 3 years still the patient was alive. So this was the outcome, and our 2 years local control is 95%, and OS was 80%, and 4 patients lost from follow-up. And local control was really encouraging. Finally, this is the ASTRO guideline published in 2017. They have said that SBRT has an important role to play in treating early stage non-small cell lung cancer, particularly for medically inoperable patients with limited other treatment options. Shared decision-making with patients should be performed in all cases to ensure that patients understand the risk related to SBRT, the side effect, and the alternative treatment available. So somebody may ask, in Bangladesh, where only few centers are doing SBRT, why this talk? This is a great radiation oncologist, Dwight Heron, who was the head of the department and director of radiation oncology in UPMC. In 2010, when I had the opportunity to be at his center, I was in a treatment planning room, and I was asking Dwight, in my country, we do struggling to do 3D, and I'm planning that maybe I will do some IMRT. So do you think that I should take interest in looking at this SRS and SBRT, because there is a cyberknife and there's a trilogy? He said, hey man, you should do, because first leap take long time, but the second leap never take a longer time. So you don't know what you are going to do. Heron, thanks you that day helped me to look into it. And today you will be happy to know that we are doing SBRT, not like you, but in our limited stage. So the take home message is SBRT is an effective treatment for T1, T2, N0, M0 non-small cell lung cancer patient who is not fit for surgery. Data are becoming matured in favor of fit for surgery patient. SBRT needs high-end equipments and experienced trained manpower. Oligometastasis, non-small cell lung cancer have better outcome with aggressive treatment, and multidisciplinary teamwork is the key of success. I always end my talk by introducing my son Tahmid and my daughter Fabiha, and this is my family with my wife Farzana. So thank you very much.
Thank you, Kamal bhai, for such nice and elaborative presentation on SBRT. I think it might grow some interest to our colleagues regarding this higher technology, particularly in radiation therapy, radiation oncology domain. Now I will request our overseas faculties, Professor J.P. Agarwal sir, to give a comment regarding this presentation. J.P. Agarwal sir.
So, am I audible?
Yes, sir.
Okay. It was quite extensive to cover SBRT from inception to the point what we reached, and I will not hesitate. It is certainly a leap. You know, it reminds me of my way when I moved on those things, right? So please just continue on that path, and someday Dwight will be very happy, Heroine will be very happy that you are also doing in head neck, the SBRT.
Yeah, he is a head neck guy.
Yeah, yes.
We have done one, sir, but the result is not so good.
So, if we have any questions?
May I request the audience to ask any question, because I have not seen any question over there in chat box. If you have any question, you can raise your hand.
So, shall I begin? Kamal bhai showed us the first patient, right? It was the age changed, the medical condition changed. So one or two things I think I want to stress upon is we should talk to the patient about the toxicity. Especially the first patient, right? Especially when we are going to do it in a few patients which are disowned by the surgeons or cannot do the surgery. So they are going to be the best PROs. So we need to talk to them about the toxicity at length. Regarding the first patient, apparently in that left lower lobe, that tumor was relatively small, but it was hugging the chest wall. So do whatever I do, there will be some contribution to chest wall. So as a planner, I need to understand how much dose I can restrict. Also, upfront to make patient understand that patient may have a chronic chest pain or chest irritability because of the pleural reaction and the intercostal muscles and nerves doses, which is going to be a bit on a relatively higher side. Once we have explained to them and they have accepted it, after the planning, we should again talk to them that what we were able to achieve in the plan. So certainly, if I have set some 30% chance of a chronic pain, with my planning, if I can substantially reduce to 20%, the patient is going to be damn happy that the team is working very well to take care for me. So that's the way I think we should involve the patient at the next step and the subsequent steps. And generally, before I used to take up the patient, I used to have a long chat with the patient. Now the physical chat has reduced, but the electronic chats goes on. And the importance of chest physiotherapy should be, I think, really highlighted, because most of them are inoperable because of the chest issues. So we must talk to them about the chest physiotherapy. Lastly, I think I want to say, I will not do a patient any treatment without a biopsy, at least in my clinic, or I'll give my full attempt to do a biopsy, histopathology. And there are several reasons to it, especially in our condition. And I think in West also it is going to increase. So the biopsy may change to liquid biopsy in the West or even in India in coming years, but a biopsy is indicated. The reason for, because if you want to do a subsequent adjuvant treatment in your subsequent, like in driver mutations, you like to do something later. If there are metastases, it helps. A small tissue helps, you know. So that is the reason of doing a biopsy upfront. Okay, there is a question. I think I should stop now.
So may I request Dr. Devras to ask his question directly to Professor J.P. Agarwal sir or to the speaker?
My question was to the speaker. Sir, very good presentation with lots of details and lots of information for us. My question was, what is the immobilization technique used in United, and what was the motion compensation technique? Was it active or passive? So
to answer your question, that we don't use the I have shown a picture that sometimes in some center they use abdominal compression, but we don't use it because most of the time we found it is not comfortable. We use 4D CT, and then we do the plan on average MIP image, and then we do the plan on that. So if you ask me that classically, there is no critical immobilization used for lung like frame or abdominal compression. Yes, we use the patient positioning by backlog, but not for this abdominal compression. And as we using every patient with 4D CT, except with a very bad breathing, not lung for other abdominal organ, there we take a risk, but for abdominal, without 4D CT, we don't treat it. So actively, we do the tracking of the patient, but not like CyberKnife, because real-time tracking is not possible in Linux, which is possible in CyberKnife. Kartik, are you there?
Just a minute. If I just want to add something with Kamal bhai.
Yeah, please.
Immobilization device usually we use knee rest.
Sorry. Sorry, Shuman. Yeah, please go ahead.
Knee rest and wing board. And regarding this motion control management, there is active and passive, as you know. Here in the United Hospital, we use active motion control with Varian RPM system. We used to put a respiratory marker over the chest wall, and with the tracking system, it usually track the respiratory movement. So you use, there are two type of active respiratory movement system. One is Varian RPM and another one is by Electa, that is ABC active breath control. So as United Hospital as the Varian machine, so they have, we are very familiar with the RPM system.
Shumon, I have a question.
Yes, please.
Not one. So congrats, Dr. Kamal, for excellent presentation as usual. My question is to Professor JP Sir. So from your experience from your clinic, what were the common toxicities you faced for your initial patients, and how could you manage these toxicities for your, or reduce these toxicities for your subsequent patients?
Okay, so we will go step by step. So definitely in the beginning, we used to treat with the 3D CRT. And now we routinely do a VMAT. So in a 3D CRT, the dose spill was a bit more, the time taken was a bit more. So definitely the spillage was more, and the patient was reflected in terms of little bit of cough. And also the tumor size, though it was small in the beginning, and we became little bit more confident, and now we can treat certainly some patient with 5 centimeter also. Earlier we started with the peripheral, and nowadays we are doing ultracentral too, but with great caution. So the main symptomatologically, they were having in the symptoms of cough, that is mild pneumonitis, and the way used to tackle was simple bronchodilator and occasional steroids from the inhalation, which they were already using it most of the times for their COPD. 2 patients I distinctly remember, we had a skin issues, and one was a very superficial ulcer. We expected it, and it happened approximately 1 month after completion of treatment. So we had to use, what we here use is amnion dressing, which is very, very uncommon. Amnion is that womb's membrane. So instead of a deodorm or a collagen dressing, we use amnion because the healing is great with that. And rest, I didn't think we had any other issues. One more patient, we had a massive hemoptysis. And since it happened along with SBRT, so I say maybe SBRT, but we were pretty sure that this patient will have a hemoptysis because that was a big cavity, okay? And it was an eroding cavity with a blood vessel pointing towards it. So in patients with cavity, we use even contrast to see there is a possibility of a bleeding or not. So that patient had a bleeding, which was a massive bleeding, but we were able to control with angioembolization. And the last patient, I think what we had was, we were unable to complete one patient's treatment, and because the patient deteriorated not from the lung issue, but from CNS issues. So basically, this gentleman had a stroke, so we had to curtail that the last day of SBRT. That's all I can remember. So we have done 100 odd patients, okay? So Dr. Kamal and everybody is not far away. They will cross even us.
We hope so.
I want to say one thing, that my apology. Actually, when JP was talking about the first patient, suddenly our first patient came into my mind, and it was a HCC patient. I don't know, Shuman, remember or not. Yes. It was a 20 centimeter, 15 centimeter tumor. And as JP was asking, we told him that we never treated a patient. you may die. And the patient was ready to die because he said, I know I'm going to die. And finally, if there is an option, we go. So when the question of immobilization came, the total thing of that, this hepatocellular carcinoma patient was in my mind. So I was talking about this immobilization. Sorry for that mistake. Suman was very correct, because I remember in Tata, they have shown that single leg rest make all the internal organ fixed. And they have they were shown me in 2009 that putting a patient in a backlog with or without a leg rest, the leg rest make the all big difference. And when you are putting your the wing board, that is fixing your arm. So for lung, actually when you are doing the 4D CT, the leg rest is the most critical immobilization device that you are using. And the wing board is to take the hand away from the body. That's all. Because remaining motion, as he was telling, that it was managed by RPM. My again apology, because I was so much involved thinking about that patient whom I lost after. And that patient we have treated twice with SBRT, and he survived for near about 5 years. So that's the longest survival first patient, and that was the HCC. So when JP was talking about the discussion with the patient or the first patient, suddenly I was very much involved with that patient. So my apology to Debraj that I answered in a long direction. That was for the HCC patient, and his breathing was very bad. So we couldn't use the 4DC2. We used the leg rest and the, this backlog for that patient. So that was my comment. Now
Thank you. Thank you. Ullas just joined? Whether Ullas just joined?
Ullas joined.
Yes. Hi, Ullas. Great to have you on board.
Yeah, Ullas sir, very good afternoon. Would you please give some comment regarding the SBRT from the medical oncological point of view?
I just joined actually, so I don't think I've heard the lecture.
No. So that's why I didn't ask you for give a comment regarding the lecture. I just want a comment regarding the SBRT in the medical oncological point of view, particularly for non-small cell lung cancer.
I think, SBRT, there are two roles basically, if I can just gather my thoughts here. First is for the primary treatment of the lung. Second is for the treatment of oligometastasis, oligoprogression. Then is the brain treatment, definitely for oligomets, oligoprogression, where I definitely think it is a huge role. And what is now coming up, and what will, what will be music to Dr. JP's and every radiation oncologist here, is the consolidation treatment to the residual primary after you have got a great response to treatment. Between SBRT and surgery, I am in favor of SBRT. Surgery, whatever said and done, is a slightly invasive procedure, and I always feel in stage 4 and lung cancer, slightly difficult to, handle that. But I think with the new targeted therapies which we are coming, we need to assess the local treatment also very, very well. The primary needs to be treated, the residual disease needs to be treated, and that may not improve a great overall survival, but definitely PFS, and then consequently OS and the change of therapy may improve. So there is, from the medical oncology point of view, there is no great, as for from the patient point of view, there is no better thing in life to find out an oral pill or an immunotherapy still going on what you were before. A known devil is better than an unknown devil. So if you have a known thing going on, you have oligomets over there, give RT, and hopefully we have got patients who have gone for 6 months, 1 year after that. So I don't know whether I am making sense or not. I am slightly incoherent because I just joined the conversation, but I think SBRT is a very useful tool.
I think, Ullas, you just hit the nail. I think with radiation, we can expose the tumor antigenicity to so many folds that even a systemic therapy will act in a much better way. The hypoxia will dissolve, the antigenicity will improve with IOs coming in and so many things happening, I think definitely it will be a game changer.
Yep, agree with that, sir.
Thank you, sir. There is a question.
Getting the effect of IO more better with the radiation. As JP was telling, the immunogenicity is increasing. The responsiveness becoming better in post-radiation patient.
So my take on that, sir, is there is a radiation oncology point of view, there is a medical oncology point of view, there is a science, and there is practical. So, you know, we all speak about the abscopal effect of radiation and all. I mean, it looks very good in theory. It releases new antigen, stuff like that. But we need to have more evidence. We need to have more evidence to prove this thing. And, you know, really. So it is, I mean, the point is, my point always, which I ask in my tumor board is, yes, definitely it can be done. It is technically feasible, but should it be done? That is a question. So although I mean, as a theory point, it is absolutely fine. But we need to see more evidence for the abscopal effects and the releasing antigen effects of that. And trust me, nobody will be more happier than a medical oncologist. If you give two radiations and then my immunotherapy works, I'll be very happy, sir. But I need to see more results.
Okay, Ullas, I think you can confirm with KP. The first patient was one of the doctor's father, physician's father, and a brain mets with performance score of nearly 40. Okay. Unfortunately, the wife was having CA breast, and this gentleman was something. So they were really, really adamant that they are ready to take a IO. So I said, okay, we will radiate. We were making that brain, we should just make it best supportive care. So we radiated something like 20 in 5, and we gave Nemo. And that gentleman became rock solid after 2 cycles.
Wow.
Believe me that.
So I do believe you, sir. I don't have to ask Kamal for that. But the point is, we need 100 patients.
So we need 100 patients. Large number. So but these become source of inspiration that you need to work harder. It is much more beyond what we actually see in life. And you know the worst part? The worst part of the story, it remains, and it just, it spreads the goosebump. The lady passed away with CA breast. Can you imagine that? She was ER/PR positive. So it gives us that we are so innate and we don't know many things in life.
Sir,
but we have to work on.
My take on this is, and generally what has happened is we should, and my take in general in oncology is we should respect each other's specialties. Yes. I cannot do it alone. I mean, it is we who can do it. And you know, it is a very cliched statement, and you know, people think that as I am growing Buddha, I am, you know, saying this more. But I have seen this happening, sir. It is only chemotherapy, only radiation, only surgery is not going to help. We can make it. We have to have a synergistic combination. That's my
team works.
So I think there is a supplementary question regarding this issue. It was asked by Dr. Rahmatullah Bhuya. If there is residual after SBRT, what will be the next plan? I think this should be answered by Dr. Ullas Batra. If residual after SBRT.
So it depends on when do you have a residual after SBRT. So I mean, very important is don't do a scan in 6 weeks time and say that there is a residual over there. So give it a 3 months at least over there. So first of all, very important. And second of all, what modality do you use after that? So, you know, I mean, one thing is in all the trials, which you see earlier, it is a CT scan chest which has been used. But what happens in our scenario is because PET CT scan is cheaper than a CT scan, we use a PET CT scan. It lights up over there. So my take, right, and the point here is, you know, if I don't do a PET CT scan, somebody else will do. So sitting in Delhi, I have to do a PET CT scan. So my point is, how I evaluate is, we do not do a scan before 3 months. Do a scan after 3 months, maybe a CT or a PET scan, see how the activity is. If it is some residual disease, do a biopsy, confirm it. Then look at the biology of the disease. If it's the only site, if it's a massive progression, systemic progression, no progression, and then deal with it. Surgery is definitely an option. If that is the only site amenable, why not? So that's my take, but I think JP can take it also forward from here.
So also I think when we do a biopsy, at this point of time, one of the integration is to do whether they were driver mutation or not, whether they will tolerate a systemic treatment or not. So here comes the concept of oligo residual disease, I think,
Yep.
or oligo solitary residual disease. So these needs a very careful discussion with the patient, what is the expected outcome, and then take a call whether to which way to go. Because many a times, if you have done in a very elderly gentleman SBRT as a lone treatment, they may not be able to tolerate a very full systemic chemo. So unless and until there is a frank progression, be on a guard, you know. Masterly inactivity is one of the treatment, I think. Especially if they are really with multiple comorbidity and very bad lung, poor tolerance, ejection fractions very low, and they are driver mutation negative. Okay, so these are the patients we should be very, very careful to start a systemic treatment. But believe me, the real potential, if you really want to harm in some major patients, I think systemic treatment has to come in, because most of the patients are going to die with distant metastasis in this group of patients.
But sir, considering these patients are from very early stage, T1, T2, N0, so would you go for just for driver mutation for this type stage of patient? T1, T2, and N0 patient, would you go for the driver mutation testing?
I think so. I think once the ADAURA matures, which Ullas can say on that, in a post-op situation, how the osimertinib has made a difference. At some point of time, post-SBRT, even it is going to come in somewhere down the line. But still, we don't have the mature evidence to say that. But it is going to come at some point of time in the literature.
In this point of time, should we go for this driver mutation for this patient or not?
Suppose it's the oligometastasis.
Not metastasis. Not
no.
Metastasis. The primary disease after SBRT.
No, we are not doing it right now. As a routine practice, no driver mutation testing in T1, T2, N0, N0, either adeno or squamous, straight away hit to local treatment only.
So my take on this would be, I mean, I think what they're trying to ask is if there's a T1, T2, N0, M0, we have given SBRT. After 3 months, there's a residual disease. Is that what your question is? And what would you do if there's residual disease positive? Is that, doc, what you're asking? Okay. So I would do a biopsy. I would want to see whether it's a only site of lesion. I would like to see the performance status of the patient. I would like to see the general condition. If it is still surgically amenable, I would like to do surgery for that and then go ahead with give 4 cycles of chemotherapy. If the EGFR mutation comes positive, I would then probably be very tempted because to give osimertinib also, not gefitinib. Please remember osimertinib. We need to remember lung cancer is basically a systemic disease, and anybody who is not responding to SBRT in 3 months of time doesn't really have a good biology of disease. And so whatever said and done, if not now, the disease is going to come back. But if you can take it out surgically, we should take it out surgically at that 3 to 4 months of time, depending on the performance status. And please do an MRI brain because we have burnt our fingers, not fingers, burnt our hands, toes, everything if we have not done an MRI.
Plus, I have a question. I think there are quite a few number of trials going on with SBRT with TKI. They are trying to use it concurrently, neoadjuvant, adjuvant in different setup. On TKI, they are trying, but it was ongoing and no mature trial. If I'm not wrong, yeah, if I have gone through, a good number of effort is going on, as Dr. JP was telling, to bring the TKI either concurrently or before or after with convention and also with SBRT in lung.
Sir, you are absolutely right. They are going on, but I think I am slightly skeptical of osimertinib, at least along with RT, because the incidence of pneumonitis will be slightly a bit higher with that. Remaining, I think ADAURA has come. ADAURA I mean, to me, if the cost of osimertinib can be kept manageable, see, it's one thing, sir, to have a disease coming, see, to live disease-free in an adjuvant setting. I am all for ADAURA. I mean, you know, to have a disease-free, do a PET scan which says no metabolic active disease in the body is far more better than, you know, good partial response to treatment. Also, we should remember that once the patient recurs, 30% of them don't take treatment. So you might just lose one of those patients. I would again say, sir, if we have a match between India and Bangladesh, you would want Virat Kohli. I mean, I would want Virat Kohli at number 2, number 3, and Bangladesh will want him at number 6.
I
So
love
I
you.
want to send my best batsman up front.
The cricket comes up. We Indians love cricket, huh?
I know.
So thank you,
Everybody, Indian subcontinent loves cricket.
Everybody, sir.
I want to bring one issue in the discussion that you can see that both JP and Ullas was talking that don't do the image after 6 weeks. This is number 1. Number 2, do after 3 months. Number 3, even it is PET positive, do a biopsy, because don't jump in to a conclusion, even looking at PET CT, because we have seen that sometimes, I mean, to take a decision that it has failed, like surgery or SBRT, it is such a curative disease, to conclude only PET may not be enough to go to a new modality or give some time. So the very important, again and again, it is coming, is you do a biopsy, prove that there is some residual, then that whether it's a chemotherapy or targeted therapy, whatever it is. So it is not a quick conclusion and not a incomplete conclusion by 6 weeks.
Apologies for coming in. So at Tata's, we generally do definitely after 11 weeks, okay, a scan. And even if we think it is a stable disease, we hold on to it.
Yes.
We repeat a scan another after 3 or 6 months, or depending upon the patient's symptomology. We don't even do a biopsy at that point of time. So there are definite radiological signs of a local progression. Okay, even a small activity of a PET, unless until you have done a serial PET and they are increasing, right? So we don't do a routine PET serially, unless and until we are mandated by the symptoms. So what Ullas was saying was very pragmatic, practical situation, that if he's not doing it, people go for shopping and somebody else will do it, right? So be very careful. So the data for saying a local recurrence on a radiology, there are very 6 points on that, okay? People can go and read a Parma's paper where they have very beautifully, Dahele and Parma has written it, very beautifully they have said it when it is considered to be a local recurrence, because you are giving a very high dose per fraction. So they're going to be a very dense fibrosis. They're going to be inflammation, right? And if you are not hitting correctly, even if you are doing a biopsy, you will have a false negativity, which is going to be very, very high. So be very careful whenever you want to take it. For us, because we are mostly doing it in inoperable patients, so the surgical salvage is nearly impossible in our scenario, because they were the bad ones to begin with. So the way we do some salvage is by RFA, and that too in a very selected group of patients. Otherwise, most of our patient has failed systematically along with locally. So it is always a systemic disease, systemic treatment.
I mean, I would agree, Dr. JP, and I mean, that is what the discussion actually brings out. See, we were all talking about the same thing but in a different way. So I was basically talking about a very early stage lung cancer where surgeons were not involved, and then we gave SBRT. Dr. JP was talking about patients who were inoperable and then SBRT was done. So see, and very important is have your radiologist who deal only with maybe to say lung cancer is a bit too much, only oncology, who do only oncology reporting. it's again the team effort. If I am good, somebody else is good, the results will be much better. In fact, I would like to add on to this, I mean, recently, in the context of the radiation to the brain also, sometimes what happens is they give SRS to the brain. And after 3 months, 6 months, the radiologist who has just joined will write the size of the lesion has increased, progression of disease. Now, what happens is, how do you define this versus radiation necrosis versus, so you need to do a MR spectroscopy or you do something else. And the last study now has shown that, even if you operate them, most of them have got radiation necrosis. So it's very, very important for everybody to be on board. Oncology is not everybody's cake of tea. And again, we as a team are dependent on each other. But first, we should know. See, I came over here. I learned from my radiation oncologist. I learned from Dr. JP. I learned from my radiologist. We need to. नहीं sir, sir जितना बुरा है sir आपसे ही सीखा है अब क्या करें? I am not crediting you for the good things, sir. I am crediting you for the bad things I know, sir.
Many, I have learned. It's everybody,
Yes.
Every student has been my teacher.
So I think a healthy respect for everyone is very, very important.
So thank you, sir. If there is no more questions,
sir, I have a question, sir.
Okay, yeah, proceed.
Thank you, sir. So my question is, if a patient with lung cancer, upper lobe or middle lobe lesion, T1, T2, N0, M0, but patient have minimal pleural effusion, which is proved to be as non-malignant for benign lesion like pulmonary TB or any other case, then can we consider SBRT for this case, or should we consider for surgery if there is no other comorbidities?
Who want to answer this question?
Dr. JP will answer this question. JP.
Okay.
Sir.
Pleural effusion, a small sliver, is not a contraindication for surgery. So in fact, if my surgical colleagues, they will go ahead, do a thoracoscopy and make sure that there is nothing else. And if there is doubtful, they will even take a biopsy, do a FS, and go ahead and do a lobectomy with mediastinal dissection and complete the story. So that will be the whole thing, followed by a adjuvant treatment. Okay, so that's the whole complete story.
Okay, so now, is pulmonary TB is a contraindication for surgery or radiotherapy, no. SBRT?
No. So you are asking an active pulmonary COX is generally a no-no for a treatment for oncology in case. So what we do is we start with anti-COX, make sure that he becomes AFB negative, healthy, and then we go ahead with the treatment of the oncological perspective, whichever it may be.
Thank
you, Riyad. So hopefully you have got your answer. So I have not seen any more question in the chat box. Thank you all the faculties for sharing their lifetime experience. I think we won't find it in any literature or books. So thank you again. So now we want to forward our next session, that is the case discussion. Shumir, I want to share my screen.
You are allowed, sir.
So is it okay?
It's visible, sir.
Yeah, can you share my screen? Can you see my screen?
Yes, everybody can see your screen. Go ahead.
So today's case, a 46 years old male patient, ECOG 2, he was initially diagnosed MI, acute MI, inferior extensive MI, just 2 months back. Fortunately, he was recovered with the angioplasty management, but the MI have done a permanent loss in his cardiac function, ejection fraction 42%. So during the cardiologic evaluation, the cardiologist found a tiny lesion in his right upper lobe. But at that time, they were very keen to cardiologic management. So when they discharged, they advised to go for a CT scan after a while. So after 1 month's time, this young man did a CT scan, contrast enhanced CT scan, and they found that there is a solitary lesion around 3 centimeters, which was contrast enhanced. So with these findings, he has done a FNAC and it comes out as squamous cell carcinoma. And then oncologist opinion, a PET CT scan was done and no lesion was elsewhere found in the body. So there is a 3 centimeter lesion. It was staged as T1N0M0. So considering this scenario, what are the treatment options that we can offer to this patient? Surgery, radiotherapy in any form, either the conventional fractionation or SBRT, or there is another modalities that is the RFA. So what we can offer? So surgery, regarding the cardiologist point of view, from the anesthesiologist point of view, this patient is medically inoperable. So what about the radiation therapy? So I will come later. So what about the RFA? You can see that the comparison between RFA and SBRT, and you could see that the comparison is quite non-uniform. That SBRT around 3,000 patients, where RFA was around 300 patients. But even with these numbers, they have found that the locoregional control with RFA is quite low, significantly low. Though they finally concluded that the overall survival is quite similar, but you could find that there is a very irrational comparing between the number of this patient. So we could find that RFA is not equal even with the conventional fractionation RT. So we could think now we can offer this patient either conventional fractionation RT or SBRT. So what we could offer? Definitely by this time, you could have get an idea the superiority of SBRT over conventional radiation therapy. So we have opted for SBRT for this gentleman. So SBRT, you could see that the medical oncologist guy like Ullash Bhatra, the ESMO endorsed these modalities. At first, it was in 2013. And after 4 years' time, the radiation oncologist guy recognized this. So it is the medical oncologist guy who recognized these modalities at first. That the SBRT is an option for the medically inoperable or unwilling guy in early stage lung cancer patient. So when you opted for the SBRT, these are the questions that were asked by patient. His first question was, so you were opted for radiation therapy, whether it is equal to surgery? Number 2, why not conventional RT? As you know that the SBRT comes with a lots of toxicity package. So after the treatment, how I will be followed up? So do I need any further chemotherapy? So is there any scope of immunotherapy? And last, whether it is possible in Bangladesh. So during next time of within 10 or 15 minutes time, I will try to cover all these questions that were asked by my patient. So first question, is it equal to surgery? So all of us already know that to compare between these two arms, we need a randomized control trial. So these are the two trials, that is STARS and ROSEL. It was initiated, but unfortunately it was closed due to poor accuracy. But the pooled analysis between these two studies already Kamal discussed a little bit over these things. That there's pooled analysis, there are around 58 patients, 31 was treated by SBRT and 27 was treated by surgery. So these 58 patients, you could see the overall survival SBRT 95%, 3 years, and surgery 79%. Most interestingly, among the ROSEL trial, the ROSEL was done by the Dutch guys. They have taken a number of patients without histopathology or cytopathology diagnosis. So these are the guys who doesn't have any performance status to do even for FNSC. So with this guy, you could see that the performance status was so poor that they were not able to go for a FNSC. These guys were treated with SBRT, and with this poor performance status, the 3 years overall survival was around 95%. So that is the beauty of this SBRT. Now come to the next landmark trial that was published in 2010. That is the Texas guy, the Robert Timmerman, the hot guy in SBRT arena. RTOG 0236, it showed that 56% 3 years overall survival. So this paper was reviewed after 10 years time, and it was published in 2018. And you can see that the 5-year survival rate is around 40%. So it is comparable to any other surgical series. Now, you can see that the most of the time, the SBRT was tried with inoperable patient. So what happens when the good quality performance status patient was treated with SAVOR? And you could see this is the paper with the Dutch guys and this is the paper with the American guys. These are all very recent papers. And you can see that the patient with the good performance status are doing good in respect of overall survival. You could see that the RPA class 1 is doing good. Here you can see the operable patients are doing good in respect of overall survival. So we can consider that if patient is medically fit, then the SAVOR could do better. So whether this answer between these two modalities, surgery versus radiation therapy, which one is superior, it will take some time. You can say already Kamal bhai discussed these studies, that this all study, it will take around 2025 to 2027 to get this answer whether surgery versus radiation therapy, which one is superior or not. So still it is a debate. So not only for the medically inoperable patient, but all patients irrespective of medical fitness, whether this stereotactic radiotherapy can be a primary treatment for this group of patients. So regarding this question, surgery versus radiotherapy, SBRT, the meta-analysis and the last conclusive words that the SAVOR is near equal to surgery, regardless of the extent of surgery, considering the lung cancer specific mortality. However, all-cause mortality was higher for SAVOR compared with surgery. So we think that SAVOR was not at least inferior to surgery. Now come to the second question. So why SAVOR? Why not the conventional fractionation radiation therapy? Now come to the very historic comparison that the RTOG 236, I have already said that the SBRT 54 gray in 3 fractions, 5-year overall survival is 40. Where the Q et al., it was published in 2003, it was shown that the 60 or 66-day conventional radiation therapy, the 5 years overall survival rate is around 21%. So the 5-year survival rate is doubled with SBRT comparison to conventional fractionation. And there are some meta-analysis also. You can see that the 2 years overall survival and towards disease-free survival is quite high with SBRT. It is the trend, it was still shown by Kamal bhai that the rising trend of SAVOR over conventional fractionation radiation therapy. It was the Chisel trial by the Australian guys. It was also discussed by Kamal bhai that the SAVOR is also superior in the progression-free survival in respect of overall survival, particularly for early stage non-small cell lung cancer patient. So come to the next question. What are the potential toxicities? So SAVOR-related toxicities, the most significant toxicities are chest wall pain, fractures, rib fractures. Sometimes the chest wall pain is so intractable that the patient may need morphine. So we need to be aware of these things. Second issue is pulmonary toxicity. In general, patient with good lung function, we need not to very serious about this issue. But if there is a pre-existing interstitial lung disease, we need to be very cautious because this might be very fatal. In a country like Bangladesh, where smoking is a very common practice, so most of the lung cancer patients might present with interstitial lung disease. So we need to be very cautious regarding the lung function, lung condition before considering the SBRT. Regarding the quality of life, it is very well maintained. And a very interesting data that the mortality after a severe, as it was the Dutch cancer database, which found that the mortality rate after 30 days is 0.7% and 90 days 2.9%. So SAVOR is associated with mortality. But very interestingly, they found that if the patient is kept untreated, the 30 days mortality rate around 33%. So it is better to get treatment rather than keep him untreated. So SAVOR-related toxicities, you could see this is the picture which was presented by Suresh Senan in last ESMO Asia. You could see the rib fracture following SBRT. So the reef fracture is a area of concern, and the risk factors regarding the reef fractures are tumor to chest wall distance, maximum dose, and dose to reefs. So we should keep it in mind regarding SBRT, the radiotherapy dose planning. Usually the chest pain usually occurs after 9 months of time, and sometimes it takes around 2 years to get this fracture. So most of the time, these fractures may mimic with bone metastasis. So keep in mind that every time patient presented with this type of pain, sometimes PET CT scan can found a little bit uptakes. So before considering it as metastasis, consider about the reef fracture regarding the saver. So I have already mentioned that interstitial lung disease is an area of consideration before giving saver. So you could see that this paper published in the Practice of Radiation Oncology in 2016, and you could see that if patient doesn't have any interstitial lung disease, the grade 5 radiation pneumonitis rate is around 2%. But if the pre-existing ILD is there, the grade 5 pneumonitis is around 21%. So it's a very significant challenge that may be faced by the treating physicians. So this is a very interesting picture that what ILD can be the cause of death following SBRT. This is the Korean paper. You could see that this first slide was done before SBRT. After 1 month, it was like this, and after 2 months, you could see what saver has done a patient with existing ILD. And ultimately, it caused death of this patient. So before considering the saver, you could think about the ILD status of this patient. So another issues regarding the saver-related toxicities, that is the bronchial stenosis, which more commonly found in the central or altocentral direction. This is the slide. You could see that after radiation therapy, you could see the left bronchus started to shrink. And in the last slide, you could see that the basal bronchus is stenosed with lower lobe atelectasis. So bronchial stenosis is another side effect that really we should consider. So these are the toxicities in summary: the chest wall pain, reef fracture, radiation pneumonitis, particularly for interstitial lung disease, and bronchial stenosis. So we should keep it in mind before going to consider for SBRT. So now the next question, how I will be followed up. So there is a long discussion regarding these follow-up issues. So according to ESMO recommendations 2017, the surveillance should be done at least 6 months with contrast enhanced CT scan for 2 years, and thereafter an annual visit. And regarding the PET CT, there is number of false positive reports. So the PET CT is not routinely encouraged for follow-up. Here you can see the challenge that JP sir and Dr. Ullash tried to cover, that the post-saver fibrosis versus recurrence. So how we could differentiate. So this is a really challenging areas. So the radiological friends find some clues to differentiate between the recurrence versus post-saver fibrosis. You could see that 5 points we need to keep it in mind. That number one, the enlarging opacities. If the opacities are enlarged over times, we need to be really cautious. If the growth is craniocaudal, we need to see it very seriously. Loss of AR bronchogram. If you can see that the earlier CT scan, you could see the AR bronchogram, and the next CT scan, you don't find. So you should track this patient very meticulously. And if the margin getting bulged, we need to keep it in mind. And loss of linear margin, you could see that linear margin over here changed with some bulging margin. So these are the 5 points which can be considered as high risk radiological features. So keeping all these 5 risk features, the SABR follow-up guidelines is like this. So if any high risk features are absent, so the follow-up should be on routinely 6 months contrast for follow-up. So if there is one risk factor, we should shorten this follow-up time. Instead of 6 months, we should do the CT scan 3 months time. And if there is 2 high risk factors, we could do a PET-CT scan and we do a biopsy. So these are the follow-up guidelines as per the high risk CT features. So not only the radiation oncologists, these are also challenging to our radiologist friends, and this is also reflecting in their journals also. So you could see the stereotactic body radiation therapy, early stage of non-small cell lung cancer, a primer for radiologists. So they are still thinking in the same way. So the next question, do I need any further chemotherapy? So you could see that even with the highest number of local control, the maximum failure is distant failure, 20%, 21%. So as per the guidelines, if the lesion is more than 4 centimeter size, after surgery, we usually offer some adjuvant chemotherapy. So why not after SAVOR, we could offer some chemotherapy that will produce some good outcome. So hypothesis is there that the chemotherapy is going to produce some better outcome. Let's see. So this is the publication. It was published in February 2019, Lung Cancer Journal. And there they found that out of 24,000 patients, 3 years overall survival was 41 with adjuvant chemotherapy compared with 50.6 without adjuvant chemotherapy. So those patients who were treated with adjuvant chemotherapy resulting 9% less overall survival, 3 years overall survival. So they finally conclude that adjuvant chemotherapy is not going to produce, rather they are declining the overall survival. So chemotherapy is not the answer. So this is the era of immunotherapy. Why not to try it with some immunotherapy? So we have already heard some newer terminology, abscopal effect, newer immunogenic primer. So why not to try it with immunotherapy? As you have known that the Pacific trial after adjuvant durvalumab produced some good results. So why not to treat there in SBRT? So hypothesis is there. So giving the right answer, we need to wait. There are a number of trials coming there after SBRT, pembrolizumab, nivolumab, and durvalumab. They all are tried, and they are in the phase 1 trial. There, some of them are still patient, have started to acquire patient, and some are even in the regulations authority level. So the time will come up when this question will be sorted. So right now, the answer is no. There is no option for immunotherapy. So at last, I want to conclude that with all these questions, we have convinced our patient, and we have treated the patient in 2018, 50 grade 5 fractions, and last follow-up is having a good quality of life with regular cardiac and radiological evaluation. Thank you. Thank you all. Hello?
Please go ahead.
So I have done the case presentation. Now I would like to request our faculties to give any comment regarding this case.
I think I will agree everything except the RFA was not an option, especially in this patient for 2 reasons. One, that patient must be on some anticoagulants. So that was the reason you did a FNA.
Yes.
And second, it is an invasive procedure. So any compromise on lung in terms of pneumothorax will maybe a challenging for life. And the more likely of a pneumothorax because it was a very superficial lesion near the chest wall. If you would have been surrounded by complete lung, I would have still thought of doing something else than the maybe even a biopsy and a RFA at the same sitting, but definitely not in this patient.
Thank you, sir. So actually, these were all the options that were discussed with this patient. So I was not agreed with the RFA, but I do disclose.
No, I completely agree.
Yes.
So even the options, I would have really thought about all those things.
So JP, I have a question to you.
Yes, please.
The data is telling that the grade 3 or grade 4 toxicity is quite low and we are quite safe. But the moment there is a ILD, the total scenario is changing, that it is coming to 30%.
Right.
So we know in many patients, it is not very easy to identify a pre-existing ILD in a very low level. Say, many patients all of a sudden they show up. So because other than doing the pulmonary function test, so in this type of old patients, 60, 65, or even 70, 70 plus, what precaution you are going to do to identify this high-risk group of patients?
So certainly, sir, I think that's quite a remarkable and very pertinent question. So overall, the ILD is something like 2% to 7%, depending upon whatever series you like to choose. So in this group of patients, before you do SBRT, we do pulmonary function test and DLCO. So they are almost like a mandatory requirement for two reasons. One, to give an opportunity for the treatment of the COPD or even a low level of ILD. So the picture what you saw by the Uddin was quite extensive ILD, which resulted in a gross hypoxemia and death. It is something like a patient who was on the wheelchair and treated with a VMAT, and then he passed away because even a low dose was not taken care of. So in some of these patients, we are very careful that we don't treat even with 5 gray volume should not be more than in R2 centimeter. So that's the precaution we should be taking. And definitely you need to work with your pulmonologist to find out those things. Otherwise, it is going to be a bit challenging for the patient and for us too.
Thank you, sir. So Kamal, is there any questions regarding these issues?
I think John has joined. You can ask him some questions. John has joined.
Hello, John. Can you
Hi.
hear me? Yes, yes.
Yeah, I only saw the last few slides. Sorry, I didn't get the invitation this week, strangely. But I caught the end of your discussion.
So we are extremely sorry. We could check.
No,
this.
no, not at all.
So regarding this SBRT, we have covered a total presentation by Dr. FM Kamal Uddin, and later we have presented a case. So from your point of view, can you say a few words regarding this SBRT on non-small cell lung cancer management?
Yeah, so I think personally, so SABRE for non-small cell lung cancer, the data where I say it shows the most benefit is patients with severe COPD, patients, it seems, who are older. You avoid the risks of post-operative mortality using SABRE in those kind of severe COPD and older patient groups. I still believe that as things stand, lobectomy for early non-small cell lung cancer is the standard of care at present. And as we know, and I'm sure you've demonstrated in your slides, the evidence at the moment of SABRE versus surgery, I'd say that there's still equipoise in regards to it, with surgery still being the optimal treatment, but there's at least, I believe, 4 studies now being conducted, which will hopefully, fingers crossed, demonstrate that SABRE for medically operable early non-small cell lung cancer is as good as lobectomy or minimally invasive surgery. So time will tell, hopefully.
So thank you, sir. Thank you for your comment. Now, is there any question from audience regarding this discussion? If there is any question? So if there is not, then we will proceed our next session. That will be a quiz session. May I request Shomi to upload this quiz over the chat box?
So John, during the link is given. So we have Dr. JP Agarwal from TMH today. So I think it will be great to meet each other virtually. Two radiation oncologists, one from UK and one from Tata. JP, he is John. He is from UK. He's a good friend of us, and he has been joining our session regularly.
Hi, John. Great to see you again.
So you are known to each other.
Yeah, yes. And we want to see you sometime physically in Mumbai too.
John, you need to unmute. We cannot hear you, John.
Apologies. So I gave a talk last weekend actually at NELCON that's on this weekend and last weekend. So yes. I did the Sabre versus surgery talk for NELCON, which was very good.
So Sabre is speaking up in this continent too. It's nice to see that.
It's been great, you know, it's changed what we can do for patients who are unfortunately ruled out from the surgical options. And so I've just done my training. So in the UK, we've now got access to an MR Linac. So I did my training about 3 weeks ago. So I've treated my first patient with mediastinal lymph node disease on a background of non-small cell lung cancer. And it's incredibly impressive, you know, the new technology coming through in terms of real-time imaging, MR imaging, so you can see the patient's tumor moving in and out, as can they, and they can just hold their breath in the treatment, you know, position. It's incredible, really incredible.
So the ultimate benefit of mediastinal lesions may be exploited in even lymphoma, who are going to live long, you know. Even the doses are going to be low, especially a lower mediastinal lymphoma, where we are very concerned with the high doses.
Yeah, so I think you're right. I think what's becoming clearer as the longer we follow these patients up, you know, it's great that we're seeing higher rates of cure, but then of course you're seeing higher rates of morbidity later. So in Barts, where I'm based, we have a thriving cardio-oncology service now for our lung, breast, lymphoma, you know, patients, so that they can be pre-optimized before their treatment, and then they can be followed up and monitored post-treatment to look for cardiac morbidity. But I think it's, you know, being thoughtful of where your dose is going and being able to employ strategies, hopefully things like MRL or even the potential of protons, you know, to spare organs at risk if you can.
But my challenge is on reporting of the doses. So the literature is full of reporting of the mean dose or even the anterior ventricular dose. But even in the moving circumstances, to report those doses with such a bit variability, even in the mean doses, I'm not sure how we are going to take care forward those doses.
So I wonder so as you probably know, cardiologists are now coming on board to begin doing full mural thickness ablation using stereotactic radiotherapy.
Yes.
And I can imagine that through MR technology that we'll have a much better understanding of anatomical doses within the heart. You know, the more detail you define on your structure, the more understanding of the dose going to those different parts of the organ, and a better understanding hopefully we'll gain of what those doses do in terms of you know, conduction deficits or vascular complications in terms of vessel damage. So at the moment, it's so basic, I would say, leading up, you know, the heart is just a round circle for most people on a planning stem.
Yes, I think their quiz time is getting over.
Yes, sir.
I always think a bit, so Chris Nutting in the Marsden, when I did my research with Chris, and I always got the feeling that he transformed head and neck radiotherapy planning so that, you know, every structure within the head and neck now is a defined organ at risk. And, you know, if you're able to make your jigsaw even more detailed in terms of the number of pieces you're defining, then you'll have a better understanding of the dose to those pieces and the long-term morbidity that you're causing with your radiotherapy, you know? So it will become more complex, I think, in terms of dosimetry and where the doses go safely.
Yeah. So say hi to Chris if you happen to just bump in sometime. Say JP has said hi.
I will. I see him in the lung MDT during the week.
Really?
Sometimes. Yeah.
Okay,
yeah.
Great. So we worked some common head neck areas in the past.
A small world.
Oh yes. Yeah, very, very small, I think. And we are a very close ties with Marsden.
Yeah, no, he's great. Yeah, it's great. Great.
Let's see what's happening on the quiz time.
Yes, so Samir, let me know the result. Okay, we have got the result. Our today's quiz winner, Dr. Naushin, Dr. Altavushan. Today we have two winners. Both of them have scored 100 on 100.
Oh God, so wonderful.
It is Dr. Naushin and Dr. Altavushan Riyad. So can you please show your face so that our foreign faculties can recognize you? These are the two brilliant guys, Dr. Riyad and Dr. Naushin. Dr. Riyad?
Yes, sir. I'm here.
Yes, he is Dr. Riyad. He is a very brilliant junior oncologist, which Bangladesh are going to get a brilliant oncologist over time. And Dr. Naushin, are you there? Dr. Naushin? So Dr. Naushin, can you hear me? Okay. So both of you are going to get our prize very soon. So sir, we are at the end of our session. So thank you our three faculties, JP Agarwal sir, Dr. John Conivier, and our respected seniors, Dr. FM Kamaluddin, for their lifetime discussions. And what's to say, our oldest friend, JP Agarwal sir, no more what to say.
No. Congratulations to the winner and all the participants. It was great to talk to you, and to you, John, and everybody. See you sometime again virtually somewhere.
Thank you, sir. Dr. John, we are really sorry for not getting the invitation properly. Let me check. Let us check what this issue. But from Oncology Club, we are extremely sorry for these events. But we wish you can continue even without not getting any invitation. You can post your time at the 3 to 5 p.m. on the Sunday. So we hope you can join every week. So thank you, Kamal Bhai. Now I wish to conclude this session. May I request our President, Professor M.A. Heiser, to officially conclude this session. Professor M.A. Heiser.
Thank you, Suman. It was a very nice session, a nice discussion. The lecture was also very good. Thank you, Kamal, for your wonderful lecture. And also Dr. JP, Conivier, and us for taking special interest in the discussion of this issues. And first, thanks to all the participants who came here. Thank you all very much. Goodbye. Bye-bye.
Thank you, sir.
Thank you very much.
Bye-bye.
Thank you very much, sir. Assalamu alaikum.
See you next week.
Thank you.
Thank you and assalamu alaikum.
Thank you, sir. Thank you, JP, sir.